All right, let's talk about the pediatric heart exam. I know, it can feel a little daunting, especially when you're up against the clock in a clinical setting. But what if there was a simple, foolproof system you could rely on? Well, today, that's exactly what we're going to unpack. We'll go step by step through a method designed to help you perform a confident, efficient, and really sharp cardiac exam on any child. Let's dive in.
So, are you ready? The answer has to be yes, right? Because by the end of our time here, you're not just going to know the steps. You'll have a solid clinical framework that you can take with you and use right away.
Okay, so where do we even begin? Well, believe it or not, your assessment kicks off the second you walk into the room. This is way before you even think about grabbing your stethoscope. It's a quick observation framework that I like to call the 4Ds.
So the first D is dimension. This is super simple, just a quick visual check. Does this child look their age? If they seem unusually small or frail, your clinical alarm bells should start ringing. It could be the very first hint of an underlying chronic condition that's affecting their growth.
The second D is dysmorphism. For this one, you're really looking closely at their facial features. Do you notice anything distinct or unusual? So many genetic syndromes have telltale cardiac issues, and spotting those features from the get-go can be a massive clue.
Third up is devices. Just scan the area around the patient. What do you see? Is there an inhaler on the bedside table? Any medications? Maybe some crutches leaning against the bed? Every single object helps tell a piece of the story and gives you vital information before you've even asked a single question. And the final D is distress. This is a snapshot of how the child is doing right now in this moment. Are they breathing comfortably, or are they working hard for each breath? Do they look like they're in pain? This gives you an instant read on their current state. And just like that, in a matter of seconds, the 4Ds are done and you've already collected a ton of info.
Okay, so with our first impressions locked in, it's time for the hands-on part of the exam. We're going to start looking for peripheral signs, and we'll work our way logically from the hands up to the head.
When it comes to the hands, it's all about efficiency. First, you're looking for clubbing in the fingernails. And here's a great tip. If the clubbing is really obvious, just skip the formal window test. It's not going to tell you anything new, and it just eats up time. After that, a quick check for paleness in the palm creases, a glance for any tiny scars from old IVs, and then a quick press for capillary refill. It's a rapid-fire assessment, but it's packed with clues. Now, this is a real game changer, especially in a timed exam. Look, you've probably got about 6 minutes for the whole station. You absolutely cannot afford to spend a full minute just counting the pulse. So, feel the radial pulse, count for exactly 10 seconds, multiply it by 6, and move on. It's more than accurate enough, and it buys you so much critical time. The water hammer pulse, it's one of those classic signs you've just got to know how to find. As you can see, you feel for the radial pulse, brace their forearm with your other hand, and then you quickly, sharply lift their arms straight up. What you're feeling for is a sudden, sharp, kind of tapping feeling in the palm of your bracing hand. That's your positive sign, and it often points towards things like aortic regurgitation. All right, moving on up to the head and neck. Think of this as a quick checklist. You'll gently pull down the lower eyelid to look for pallor. And here's a key tip for the mouth. You always have to use a torch. You simply cannot see central cyanosis or a high-arched palate properly without one. After a quick glance at the ears for their position, you'll check the neck for a raised jugular venous pulse, the JVP, which can be a sign of fluid overload. Okay, we've gathered all our peripheral clues. Now it's time to get to, well, the heart of the matter. The local examination of the chest and the precordium itself. Now, the sequence here is absolutely crucial. It's always in this order. Look, then feel, then listen. Inspection, palpation, auscultation. There's a really good reason for this. It prevents what you feel from biasing what you see, and what you hear from biasing what you feel. It's a system, and it works. Inspection isn't just a quick glance. To do this right, you really need to see the chest from multiple angles. Start on the patient's right side, then walk around to the foot of the bed, and even take a look from the left. This kind of 360-degree approach is really the only way you can reliably spot some of those more subtle scars or chest wall deformities. Next up is palpation. Your main goal here is to find the apex beat. That's the point of maximal impulse. Once you've found it, you need to figure out its position relative to the midclavicular line. Why? Because if it's displaced outwards or downwards, that's a key sign of an enlarged heart, what we call cardiomegaly.
All right, now for the part that can feel the most intimidating for a lot of people, auscultation. But don't worry, we're going to break it down into a simple, really practical method for decoding those heart sounds.
And this right here,
This is the most important technique of all. When you hear a murmur, you must time it. So how do you do that? You place your fingers on the carotid or the radial pulse while you're listening. If the murmur happens with the pulse, it's systolic. If it happens after, it's diastolic. Examiners will absolutely be watching to see if you do this.
Think of this table as your cheat sheet for the most common murmurs. And the key is to look for the patterns. For instance, notice how both mitral regurgitation and a VSD cause a pansystolic murmur. You hear it through the entire beat. So how do you tell them apart? It's all about location. Mitral regurgitation is at the apex and radiates over to the armpit. A VSD, you hear it at the sternal border and it doesn't really go anywhere. These patterns are everything.
Here's another great little trick. If you're struggling to hear a faint murmur, especially up in the aortic or pulmonary areas, just ask the patient to sit up and lean forward a little bit. This maneuver physically brings the base of the heart closer to the chest wall, and it can make those really quiet sounds much, much clearer.
We are almost there. The final phase involves just a few last checks and then, arguably the most important part, structuring all your findings into a clear and compelling presentation for the examiner. So, to complete the exam, you need to check the back for lung crepitations, palpate the abdomen for an enlarged liver, and check the lower limbs for any edema. And here's another pro tip for you. Save the back exam for the very end. That way, you only have to ask the child to sit up and move once. It's just more efficient and honestly a lot kinder to the patient.
Now, how you present your findings is just as important as the exam itself. You want to tell a story. Start with the headline, the patient's name, their age, and your single most important finding. Then systematically fill in the other key details. And this is crucial. Only mention the important negatives, the things you expected to find but didn't. Then you bring it all together and deliver your conclusion, the most likely diagnosis.
And get ready, because your exam will almost certainly end with these two questions. You need to have your differential diagnoses all lined up, and you need to be prepared to explain what you'd tell the parents in simple terms. Don't get caught off guard. Think through these answers before you even start.
So as we wrap up, just think about everything we've covered, from the 4Ds at the doorway to timing a murmur with the carotid pulse. What is the one clinical sign or technique from all of this that has really stuck with you? The one thing where you thought, I'm never going to miss that again. Hold on to that thought, because that's how you really start to master this exam.